Welcome to the episode that we will talk about root resorption. We will talk about its etiology, types, and management. Osteoclasts are the cells that are responsible for the resorption in any kinds that we will discuss in this chapter. We must know that osteoclasts are they are formed by the fusion of mononuclear precursor cells of the monocyte macrophages, which means that they have an inflammatory immune behavior. On the contrary, the osteoblasts and the osteocytes are derived from skeletal precursor cells, which means that the osteoclast can be stimulated to come to the injury site uh, in the same manner as other immune cells like the macrophages and the dendritic cells. The macrophages and others are attack the foreign bodies and the bacteria. As for the osteoclast, they are attracted to calcified tissues. So when we having a non-calcified surfaces, a collagen organic surfaces, they they protect the area from the invasion of the osteoclast. Keep this in mind for when we discuss the resorption types afterward. As for it, the osteoclast is a multinucleated cell. Its cytoplasm forms a non-nucleated region that is called the staining zone that adheres to the surface to do the resorption. It has finger-like projections that are called the ruffled border. Inside, beneath them, happens the resorption mechanism when it produces an acidic material, and this sealing zone makes this environment restricted in this area, and it is isolated from the surrounding environment. So, the presence of non-collagenous organic component in the dentine, which is the odontoblast layer and the predentine, prevents the internal resorption of the root canal, and the presence of pre-cementum prevents the external resorption of the root surface. This is by understanding the mechanism that the osteoclast only attach to calcified tissue means that the presence of these structures is important to prevent the resorption mechanism. But that's not the case in our episode now. Today, we will talk about the external inflammatory resorption that is usually associated with the dental luxation and the avolution. And when these happen, the periodontal ligament gets infected and damaged, which initiate the wound healing, and which the osteoclast and macrophages are attracted to the site of injury to remove the damaged tissue. When they came, and this injury, we said before, the luxation and the intrusion, the evolution, causes a breach integrity of the protective pre-cementum. This permits the odontoclast to bind and resorb the underlying mineralized cement. So when the pre-cementum is teared out due to this accident, the osteoclasts start their invasion. And we can see that this kind of resorption is actually aggressive and fast. The tooth can get fully absorbed in a manner of 3 months, usually, but in general, the signs appear after 1 year of the injury, or in some cases we can visualize the radiographic signs as early as 2 weeks after the replantation of avulsed teeth. So we must do a follow-up to these cases when they happen. The EIR relies on the microbial stimulation from the infected necrotic pulp of the affected tooth for its progression, which means that when this accident happened, the avulsion and um, the laxation, they cause a necrotic pulp and an asymptomatic tooth. So this necrotic tissue is responsible for the progression of the resorption. So our treatment is by doing a root canal treatment. There is a rule that says that the replanted teeth with closed apices, root canal should be carried out 7 to 10 days after the replantation, even if there are no radiographic signs of the EIR. As for immature teeth, the prognosis is poor for them. So we indicate its presence by the loss of the vitality, by taking the by the dental history of the patient, and by studying the radiographic images. And now let's talk about the external cervical resorption that is associated with the cervical area of the tooth, and it is usually in 45% of the cases appears with orthodontic treatment, and in 28% with trauma. It's known for the pinkish sign that we can see clinically, which represents the granulation tissue, the vasculated one that represents this type of resorption. The process of it is often asymptomatic and quiet until it proceeds to reach the pulp and causes reversible pulpitis signs that are spontaneous localized pain, tenderness on mastication, tenderness on to percussion, and can get to drainage, sinus, swelling. Here the resorption was big, and it decreased the prognosis of the tooth, so it was extracted. When it was studied on radiographically, we have seen that the predentine has protected the pulp from the invasion of the osteoclast, and we can see in this arrow that a bone-like tissue formation to protect the pulp. This case of a cricket ball player that got injured when she was 11, and these signs did not show until she was 34. It was diagnosed as an caries, and it was treated like that for all of these years. So we can see that the cervical root resorption is considered slow when compared to the inflammatory root resorption. So how do we manage the cervical root resorption? After we diagnosed the case and took the radiographic images, and CBCT is recommended to know the extension and the site, and we first do a flap, a surgical mucoperiosteal flap. After once we accessed and the lesion, we start removing the granulation by using hand excavator, or when we have an osseous tissue, we can use an ultrasonic instruments to remove these tissue, and we take a radiograph to make sure that we have removed enough and sufficient and in the right position. Then we treat the surface with 90% aqueous solution of trichloroacetic acid to cause a coagulation necrosis of the resorptive tissue without damaging the periodontal tissue, to protect the underlying structure. Then the cavity is restored with the glass ionomer or a composite, and we close the flap. In cases where there is a perforation between the cervical area and the root canal, we open the access and do instrumentation as normal, using saline as an irrigant. Then we insert a tapered 𝐏𝐻𝐿 in the canal to maintain its patency during the removal of the granulation tissue and the restoration. Then after we finish the steps that we said before, we close the flap and continue the root canal treatment as normal, without the fear of extrusion of infected tissue or the irrigance of medications into the periodontal tissue. Now let's talk about the internal root resorption. The internal root resorption is associated with traumatic injuries that in 45% of the cases it is seen radiographically as an oval or shaped radiolucency that is continuous with the pulp. Usually the apical tissue of the pulp beneath the resorption is vital, which provides nutrition to the osteoclast cells, and the pulp that is coronal to the resorption site is necrotic, which provides the continuous stimulation for these cells, and the resorption continues. So and a root canal treatment is important to remove the necrotic tissue and to remove the intact pulp beneath, and to stop this resorption process. If left untreated, it will progress to make a periodontitis lesion. The IRR lesion maintain their position relative to the root canal system on the angled view. They stay in the same position even if we change the angle of the radiographic imaging. When we do the root canal treatment, we may be faced by bleeding from the granuloma tissue, the granulomic tissue, and inflamed pulpal tissue may impair visibility in the initial stages of treatment. So we use copious amounts of irrigation with activation with the ultrasonic tips to get the things under control. Also, we can use an intracanal antimicrobial medication between the sessions, and when we are ready to do the obturation, we must do it with a warm vertical condensation using a flow 𝐏𝐻𝐿 to make sure that we get the perfect seal in all the spaces, using one of these the obtura and microseal. If we had a perforation, We can use MTA to fill the canal, all of the canal, or we can use what is called a hybrid technique when we use both, that we fill the space under the resorption with the 𝐏𝐻𝐿. Then we close the perforation with MTA and continue filling the canal with warm 𝐏𝐻𝐿 material. If the tooth has been weakened by the disease process to the extent that fracture of the tooth root is likely, the patient may elect to have the tooth extracted. That's it. Salam. Osteoclasts are formed by the fusion of mononuclear precursor cells of the monocytes macrophages. Osteoclasts are brought to the site of injury or irritation by the release of many pro-inflammatory cytokines. To perform their function, osteoclasts must attach themselves to the bone surface. Then the cell is recognized to produce an organelle-free zone of sealing cytoplasm. This is the clear zone. Attached to the cementum. The clear zone surrounds a series of finger-like projections, the podosomes of cell membrane known as the ruffled border, beneath which bone resorption occur. Under these, the resorptive area within the clear zone therefore is isolated from the extracellular environment, creating an acidic microenvironment for the resorption of the hard tissues. The external inflammatory resorption, the EIR, is usually a consequence to dental luxation and avulsion. The treatment, it is mainly based on effective removal of infected necrotic pulp. The earlier the diagnosis, management, and treatment of the EIR, the better the prognosis of the affected tooth. What is the pathogenesis of external inflammatory? Normally, permanent teeth are resistant to resorption. It is generally accepted that odontoclasts do not bind to the non-mineralized layers covering the external root surface and the root canal wall, which means the pre-cementum and the pre-dentine. A critical factor is that the pre-cementum may be stripped from the root surface during injury, resulting in exposure of the underlying dentin to osteoclast and odontoclastic activity. The clinical features, the tooth is in question will not respond to sensibility testing. EIR is always seen within 1 year after the injury. EIR can have a rapid onset and aggressive progression such that complete resorption of an entire root can occur within 3 months. The management. Therefore, it is essential to initiate root canal treatment as soon as radiographic signs of EIR are identified. An exception to this is replanted teeth with closed apices. In these cases, root canal treatment should be carried out 7 to 10 days after replantation, even if there are no radiographic signs of the EIR. For the immature teeth, their prognosis is poor for when an EIR happen to them. The external cervical resorption. Orthodontics was the most common appearing factor, causing 45% of the cases. The process is very often quiet and asymptomatic. The clinical signs, a pink or red discoloration may develop at cervical region of the tooth due to the granulation tissue occupying the resorptive defect. When the resorption reaches the pulp, it can cause a pulpitis symptoms like spontaneous localized pain, tenderness on mastication, tenderness to percussion. The management, we first get a surgical access to the site of the resorption by raising a mucoperiosteal flap. The fibrovascular granulomous tissue is readily removed with a hand excavator. However, defects containing significant amount of fibro-osseous tissue requires removing of the tissue with ultrasonic instruments. The cavity is then treated with a 90% aqueous solution of trichloroacetic acid. This causes coagulation necrosis of the resorptive tissue. The cavity is restored with composite resin or glass ionomer cement. If perforation of the root canal wall has occurred, the root canal should be prepared in the area of the defect as normal using saline as an irrigant. A quataburka point then should be placed in the canal to maintain its patency during the excavation and restoration of the resorptive defect and to provide a barrier against which the final restoration can be condensed. After repositioning of the mucoperiosteal flap, root canal treatment can be completed in the normal manner. The internal root resorption trauma was found to be the responsible of 45% of the cases. The pathogenesis is for internal root resorption to continue. The pulp tissue apical to the resorptive lesion must be vital. This provides clastic cells with nutrients, and the infected necrotic coronal pulp tissue provides stimulation for those clastic cells to continue to do their activity of eating the dentin. Diagnosis: oval-shaped radiolucency. An IRR cavity is continuous with the normal root canal walls because it is essentially an extension of them. The treatment: root canal treatment is necessary to eliminate the vital apical tissue that is sustaining and stimulating the resorbing cells. The use of ultrasonic instruments to aid the penetration of endodontic irrigants has been shown to improve the removal of organic debris and biofilms from the root canal space. The root filling material must be able to flow, warm, condensed. If perforation has occurred, mineral trioxide aggregate, the MTA, should be considered the material of choice to repair the root canal.